Hello guys. So continuing my presentations for the GI cases, um, I'm going to talk a bit about ulcerative colitis today, and it's a very important topic, and it comes quite frequently during the MCQs. There's so many questions about ulcerative colitis, and you can get this case in your basis exam as well. So in this short presentation, I'm going to give you all the information which is needed to answer these questions. So let's start. So ulcerative colitis is, as we know, that is a form of inflammatory bowel disease. And remember that in ulcerative colitis, the inflammation always starts at rectum, and this is the most common site for ulcerative colitis. And it never spread beyond ileocecal wall and is continuous. This differentiation is important, and so many times it is tested in the MCQs when we compare ulcerative colitis with another inflammatory bowel disease called Crohn's disease. I'll not go into more detail, and because I have another presentation for the Crohn's disease as well. The peak incidence of ulcerative colitis is in people between 15 to 25 years, and in those aged 55 to 65 years. So it has bimodal presentation. The initial presentation is usually insidious and patient may have intermittent symptoms. So the features include bloody diarrhea, it can be urgency, tenesmus, abdominal pain, and particularly abdominal pain in the left lower quadrant. Patient can present with extraintestinal features like arthritis, and normally it is post-articular, asymmetric, and there can be skin manifestations like erythema nodosa. There could be eye involvement causing episcleritis as well as osteoporosis. There are certain extra-intestinal features which are actually unrelated to disease activity and include arthritis, which can be polyarticular and symmetric. If it is a polyarticular and symmetric arthritis, it is unrelated to disease activity. Patient can have uveitis, skin manifestation like pyoderma gangrenosum. Sometimes the clubbing is there, and primary sclerosing cholangitis. So these are all the features for the ulcerative colitis. So moving on, let's talk a bit about the pathology. If you do the colonoscopy, you may see red raw mucosa and that bleeds easily. There is no inflammation beyond submucosa. So as I told you, that is a superficial inflammation, and we compare with the Crohn's disease, where the inflammation extends to all three layers of the intestine. So there is widespread ulceration with preservation of adjacent mucosa, so which has the appearance of polyps, so may have some pseudopolyps. And there are inflammatory cell infiltrate in lamina propria. The neutrophils migrate through the walls of the glands to form crypt abscesses, and there may be depletion of goblet cells and mucins from gland epithelium. Granulomas are infrequent, while they are quite frequent in Crohn's disease. On barium enema, one can see that the findings will be there will be loss of hostrations, superficial ulcerations or pseudopolyp, and in long-standing disease, colon is narrow and short, something called drain pipe colon. Although now the barium enema is not done much, normally we do the colonoscopy, yet it is widely available. Let's talk about the flares for ulcerative colitis. So most ulcerative colitis flares occurs without any identifiable triggers, but there are some factors which are linked, like stress, medications, non-steroidal anti-inflammatory drugs, antibiotics, and cessation of smoking. this is a very important cessation because the smoking can make worse Crohn's disease. But in case of ulcerative colitis, if a patient is a smoker, then in some way it helps the ulcerative colitis. And when the patient stops smoking, there may be flares of ulcerative colitis. So, when we talk about the flares of ulcerative colitis, they are usually classified as mild, moderate, or severe. Mild is actually we classify by number of stools, so fewer than 4 stools daily, with or without blood. There is no systemic disturbance, and the labs are normal. There's normal ESR and C-reactive protein values. In moderate, we may have 4 to 6 stools a day with minimal systemic disturbance. While in case of severe, there is more than 6 stools of blood, more than 6 stools a day, and that contains blood as well. What is the evidence of systemic disturbances? So when we talk about systemic disturbances, we're talking about patient having fever, tachycardia, abdominal tenderness, distension or reduced bowel sounds. Patient may have anemia and hypoalbuminemia. Obviously, patients who had evidence of severe disease should be admitted to the hospital. So remember, this classification is very important: mild, moderate, and severe, and there are many questions which come up for the classification and how you will manage. So actually the management is according to the classification actually. So moving on to the management. So treatment can be divided into inducing and maintaining remissions. So NICE has updated their guidelines on the management of ulcerative colitis in 2019. And severity is usually classified as being mild, moderate, severe, and we already talked about it. Mild is less than 4 stools per day, only a small amount of blood. Moderate is 4 to 6 stools per day, varying amount of blood, no systemic upset. And severe is more than 6 bloody stools per day, plus features of systemic upset. And we already talked about what were the systemic manifestations. You may have fever, tachycardia, anemia, or raised inflammatory markers. So, how will induce remission? So, if the patient has mild to moderate ulcerative colitis or proctitis, then in this case, topical, by topical we mean rectal aminosalicylates are effective. For distal colitis, rectal mesalazine has been shown to be superior to rectal steroids and oral aminosalicylates. However, if the remission is not achieved within 4 weeks, we can add an oral aminosalicylate. And moving on, if remission is still not achieved, we add topical or oral corticosteroids. So this is about mild to moderate ulcerative colitis. If the patient has proctosigmoiditis and left-sided ulcerative colitis, again the treatment is topical rectal aminosalicylates. However, if remission is not achieved within 4 weeks, we add high-dose oral aminosalicylates, or we can switch to high-dose oral aminosalicylates and topical corticosteroids. And if the remission is still not achieved, we stop the topical treatment and offer an oral aminosalicylates and an oral corticosteroids. While in the extensive disease, topical aminosalicylates and high-dose oral aminosalicylates, if remission is not achieved within 4 weeks, we stop the topical treatment and offer a high-dose oral aminosalicylates and oral corticosteroids. So summarizing this, as you can see, in mild to moderate cases, topical therapies are usually enough. However, if there's more severe symptoms and other manifestations, then we have to go to the oral therapy. So severe colitis, it should be treated in hospital, and IV steroids are usually given first line. IV cyclosporine may be used if steroids are contraindicated. So if after 72 hours there has been no improvement, we consider adding IV cyclosporine to IV corticosteroids or consider surgery. So this is the hospital management actually. For maintaining the remission from a mild to moderate ulcerative colitis flare, if there is proctitis or proctosigmoiditis, topical aminosalicylate alone, daily or intermittent, or an oral aminosalicylate plus a topical aminosalicylate, daily or intermittent, or an oral aminosalicylate by itself. However, this may not be effective as the other two options. So for the maintaining remissions also, you can see that the salicylates have a big role, and depending on the condition, we can use either a topical form or oral form. How about left-sided and extensive ulcerative colitis? Same, oral aminosalicylates, but in low maintenance dose. Following a severe relapse, more than 2 exacerbations in the past year. So in this, we go for more advanced therapies like oral azathioprine or oral mercaptopurine. So as you can see, for maintaining also, maintaining the remissions, the salicylates, these are the main medicines which are used for maintaining remissions. Just to mention few more points that methotrexate is not recommended for the management of ulcerative colitis. However, in contrast to Crohn's disease methotrexate we can use. And there is some patchy evidence that probiotics may prevent relapse in patient with mild to moderate disease. Okay, so let's talk a bit about the colorectal cancer. There are many questions because ulcerative colitis is actually related to the colorectal cancer. So risk of colorectal cancer is significantly higher than that of the general population, but there are different studies show varying rates. So increased risk is mainly related to chronic inflammation. Worse prognosis than patient without ulcerative colitis, partly due to delayed diagnosis. Lesions may be multifocal. So in terms of prognosis, in case of ulcerative colitis, unfortunately the cancers are diagnosed quite late because patient already had symptoms related to GI with some blood in the stools and may have flares. So it is diagnosed early in patients who don't have ulcerative colitis. Factors which increase the risk of cancer: disease duration more than 10 years, patients with pancolitis, onset before 15 years of age, unremitting disease, and poor compliance to treatment. Colonoscopy surveillance in inflammatory bowel disease patients should be decided following the risk stratification. So now I'm going to talk a bit about which patient and we should do the surveillance and how frequently should be done. So suppose if the patient is low risk, then we do 5-year follow-up colonoscopy. Low risk means although there is extensive colitis, but there is no active endoscopic or histological inflammation, or simply patient has left-sided colitis or Crohn's colitis of less than 50% colon. So in that patients, we do colonoscopy every 5 years. In the intermediate risk group, we do 3 years colonoscopy. The intermediate group is who got extensive colitis with mild active endoscopically or histological inflammation, or they have post-inflammatory polyp, or patient has a family history of colorectal cancer in a first-degree relative, age 50 or over. So in that group, 3-year colonoscopy is needed. What about the high risk? So high risk patient, in this patient we have to do 1-year follow-up colonoscopy, and this group of patient has extensive colitis with moderate or severe active either endoscopic or histological inflammation, or patient has strictures in past 5 years, or on the biopsy we found dysplasia in past 5 years and the patient declined in surgery, patient having primary sclerosing cholangitis, or having any transplant for primary sclerosing cholangitis. By transplant we mean liver transplant, or family history of colorectal cancer in first degree relatives, age less than 50 years. So these are the groups which are considered high risk and we have to do 1 year follow-up colonoscopy. Hopefully, this will answer a lot of questions about the ulcerative colitis. Thank you very much, and I will see you again in my next presentation. And for the time being, we'll continue with our GI topics. Thanks a lot.